guide the patients to undergo all the other treatment, then mount a diagnostic cast, whether the occlusal, everything that is in the symmetry, including from the sagittal and coronal and frontal section and the occlusal plane, everything you have to check whether it is in the proper way, or any supraeruption is there, or root stump is there, or any impacted tooth is there, or the miniatures, that is the tooth has got any kind of anomaly, the proportion wise width and length, everything, it is applicable to the facial dimension that you have to evaluate. And survey the diagnostic cast. Why we have to survey? Because always the tooth will have the undercuts. The tooth will have the soft tissue, also will have the undercuts. So how to block out the undercuts, and how they very easily they can place the denture inside the mouth, that we have to check. Then design of removable partial denture designs, because there are many type of blockouts we have to use in the design wise. Then you have to go for the easy placement of dentures. Then record the mouth preparations. In the mouth preparations, already I have told you whether the standing tooth next to the edentulous area is perfect. So how many standing tooth you are going to take for support. So that is a prime importance of your removable partial denture. Next. So review of diagnostic criteria, already I have told you. So how to locate the edentulous arches. So whether it is a long span or a short span, the condition of the abutment teeth, whether it is periodontally or endodontally, it should be viable, or it is a clinical crown wise, you have to do the judgment. Then the occlusal scheme. So how the occlusal scheme is very well, it is given to the patient, whether the patient is satisfied with the occlusal scheme, or we have to enhance the occlusal scheme for the patients. Normally, the natural dentition, the patients will have the balanced kind of articulation, they will say so, but there are some specialized prosthodontics, they will say how to take the anterior guidance and the posterior contacts for the patients. The anterior guidance wise, you have to check for the canine guided kind of occlusion, and posterior, the group function occlusion is there or not. According to the materials also, we have to check whether you are going to give an RPD or FPD, that is fixed prosthodontics, you have to check. Then the residual ridge, always the resorption rate. So you cannot say systemically the patient may have the diabetic and other untoward systemic illness. So how to find out the residual ridge resorption? Because normally they will say physiological resorption that takes place 1 millimeter per year, they will say so, for including implants. So when you are placing implant also, the patient may show the physiological resorption around 1 mm per year. So that is so. So how much the residual ridge resorption? So you can do a formula from mental foramen level. So how much the ridge is resorbed, that also you can calculate. According to that, you can change your diagnostic treatment plan. Next. So diagnosis always gives a good prognosis. So always the easy diagnosis, always from our study point of view, we'll follow only the Kennedy's kind of classification. So already you have to, know about the basics, whether it is a posterior edentulous or in the posterior edentulous saddles on bilateral or the unilateral or compound saddle placed between the natural teeth, that is in between the natural teeth, and then the anterior loss of teeth crossing the midline. So that's shown to be the class 4. Next. So again, the functional prospectors, why we have to check? So restoring so when you are going to deliver any kind of denture prosthesis, you have to ask, ma nalla kadikka mudiyudha, nalla saapda mudiyudha. So restoring the mastication efficiency, then occlusal harmony. Why this occlusal harmony? Because the mandible shows a range of movements, protrusion, retrusion, side to side movements, that is within the functional range it shows. Suppose the functional range, it is not happening, it is going very pathologically, then the functional range it's not seen. The patient may have the tendency to rotate the mandible in all directions. So this will affect the condyle also. So first you have to check the jaw stability and the jaw condyle stability also. That's called orthopedic position of the joints also. You have to check. Then supporting the periodontal health. Always remember, so patients should come to your clinic 6 months once they are saying so. Yes, it's good for the patients. So always supports the periodontal health. There should not be any recession. So always keen on that. And then about plaque accumulation, that also should be corrected. Then phonetic function and speech clarity. So when you give dentures, so all the labial and labiolingual and palatal sounds always should be tested for the maxilla, and for the lower always test any tongue kind of interference is there, everything, then frenal attachments, everything how to test and then deliver the prosthesis. Otherwise patient will say, after wearing a dentures I am not able to speak this P, B, T, D, N, everything comes like a, what to say, it is a double kind of thing. And what to say, when I say S, it comes like a, what to say, swishing. S means it comes sh like that, the sound wise. So everything should be corrected. So you have to know where exactly you have to reduce. So where exactly you have to test the sounds. So according to that, you can deliver the prosthesis. Next. So these are all very important when you are making, whether it is an acrylic denture or you are going to make a cast partial dentures. The cast partial dentures, they will say it's a sleek model and you can deliver, and it depends again, once more perspective is what type of metal you are going to select, whether it is a hard metal like a chrome cobalt alloy or the very less and very density wise very less kind of titanium alloys you are going to deliver for the patients. Next. So technology perspective, so always think of, I've told you already, so labor work, so how much you're going to pay for the technicians. So whether it is anesthetic, so you're going for other options and you're saying, no, I'm not going to, this patient is not satisfied, and patients say it's quite heavy also, you're not done a very proper trimming and other things, that also will contribute, and metal taste also. So metals always induce taste, so that are all disadvantages. Next. So metal frame process time, it takes more than 7 hours to 15 minutes to make one cast partial denture. So what are all the steps, as you all know? So the RPD designing, then comes your duplication of the cast, then about the wax pattern again you have to make it, and invest and burn out, and casting you have to do, then fitting and finishing, that you have to check, lot of trimming work you have to do, then final sandblasting and polishing, then you can deliver the dentures. Next. So where comes the perspective? So why we have to go for this more than 7 hours you have to make one cast PD. RPD means it's a headache for everybody. So what is a perspective you can see means the digital dentures you can use. So hardly it takes only the designing, it is only for half an hour, then you can do the processing, that is the scan data can be stored in the STL file format, and then the STL file format you can open it and you can do the designing, the software is there, Exocad software is there, and you can do the designing of your RPD, where and all you can do the blockout that you can do, and very well you can do the 3D kind of printers you can use, and you can deliver the processes. There are metal printers out there, and the printers for the acrylic kind of printers also, that is whatever the material we are going to use, that kind of printers also available. So you can very well you can use it. Next. So this is the easy work. This is called as the fusion, the laser light that fuse whatever the metal particles, and it is going to give it is in the flat format, it is going to deposit, and finally you will get your RPD framework. Next comes the metal free dentures. There is an update. So why for metal? There is an acrylic denture. It is not an acrylic denture. There are materials, the recent innovated kind of materials like polyamide and polyesters and polyphenols and PEEK kind of materials. This give a wonderful kind of dentures. So these are also CAD/CAM made, and digital ClearMet technique. It is not launched yet, but this is also a wonderful technique. Very sleek kind of denture material that is printed through 3D, and it can deliver to the patients. And instead of giving a stainless steel clasping, you can go for the wire clasping. So it shows a very good flexibility, and it is very well adapted, and it can be contoured to the patients. It is moreover, it avoids the recession of all the tooth structures, and gum tissue. It is very, very beneficial. So this kind of thing also it is going to be lost probably in the next year. I don't know. Next. So again, what is the thing you have to take it for? So always visualize which is the easiest classification to be taken, and whatever the components to be added for support, and that should be given, support and retention, that should be contributed. Whenever possible, cover the least amount of tooth structures, because patients always say, why you are taking out too many clasps in my mouth like that. So which is very beneficial, that kind of clasping you have to do. Or claspless or aesthetic dentures, like claspless dentures with the precision attachments you can give, or the ceramic kind of clasping, the clasp covered with ceramics, that also we can give, or the aesthetic clasping through with acetal resins or any other kind of material you can use. Next comes the complete denture. So RPD is over. So what is the perspectives and complete denture? So patient comes with a complaint. Madam, we have extracted all the teeth. Now nothing is there. So the denture should stay well in my mouth. So what are all the possibilities you can do that you can do. So I've already told you in government dental college, for 120 rupees, the patient gets a denture. Whether he is getting a satisfaction or not, he is satisfied compared to the other. I don't know because the institution wise, I don't know how much they are paying for it. But he is very happy with the dentures what we are giving. But there are some indications. So how to rule out the patients are going with a very happy mood or anything like that. So what are all? It is mandatory. So when patient comes, again I'm saying you have to maintain a data. So what data? Writing, the manual data or the digital data, you have to take it because digital data does wonderful kind of thing. Because why I'm saying digital data is very, very important. The perspective on digital data, it's going to capture the full face and profile, everything. So that should be stored in the electronic thing, and whenever you want to use for future references, you can use it. So that is one of the importance of digital data. So when patient comes, whether it is a manual or a digital data, first you have to record, do a primary and the final impression. So what is the difference of primary and final impressions? Because whenever you are doing a primary impressions, it's a overextended impressions. When you are recording the final impressions, you are going to measure the functional depth and width of the alveolar sulcus, whether it is a lingual sulcus or the labial sulcus. You are going to determine how much should be the thickness. Otherwise, when the patient wears the denture, it is like a monkey only. So you have to know how well you are going to do the border molding. So whether the digital data gives okay, you can do scanning and you can record, no. So in this aspect, my perspective is, you have to do a manual kind of procedure, register the primary impressions, then do your border molding, then you can go for the other kind of procedures, and including the interocclusal records, the centric relations, the vertical jaw relations and centric relations. You are the one to give the manual data is very, very important compared to the digital data. The trial denture insertion, you can use this digital data for everything. Next. So what is the function perspective? So patient comes, if he wants to wear a denture, he'll say, Madam, I want to eat well. So you have to check what kind of teeth you can give. Because all the cases you cannot say, untoward resorption will be there, and patient with the normal physiological resorption and internal space will be adequate. So how you are going to plan for that? So what kind of occlusal scheme you can give, whether the patient is going to have the lingualized kind of the occlusal scheme. The Dr. Piney is introduced one lingualized occlusion scheme. So it will give a martel pestle kind of action. Only the prominent cusp of the upper will come and lodge in the centric fossa of the lower. So the patient will not have any lateral kind of interferences. So it is compensated with the neutral zone. So everything is a clear thing. You can go for that. Or else a normal kind of balanced kind of articulation, because already they'll say in the textbooks, they'll say when the patient protrudes, there will be opening in the posteriors. That's called as Christensen's phenomena. To avoid that, you have to introduce balance for kind of articulation and occlusion schemes for the patients. Then muscle coordination, because whenever the age advances, the muscle coordination, the muscles of mastication and the buccinator muscle, the facial muscles, that and all, it shows as sagging. So to improvise, you have to have the correct, the figament, the vertical jaw lesion and horizontal jaw lesion should be recorded. Then the retention and prosthetic stability. So whenever you are going to do whether the primary or the final impression, you have to do a perfect work. Then only you can have the retention and the prosthetic dentistry. Then occlusal harmony and jaw stability. So everything should be symmetrical, because sometimes there will be an untoward resorption will be there. So where exactly you are going to give the occlusal plane, that is very, very mandatory, and you have to make all the references, anatomical references and the lateral line to compensate for your occlusal plane. Everything you have to take it, and xi point references that you have to take it, and you have to give a correct occlusal harmony and occlusion. Next. So technology perspectives here again. So you can reduce the visit. So that is one of the advantage of your technology perspective. So whatever you are going to register in patients, you can hand it over to the lab. So according to your digital smile design, you can configure it and you can deliver the dentures and you can visit the steps. So already you can have 5 or 7 steps the patient should come. No, you can reduce very well with the digital. So predictability by setting wise and delivery wise, it's good only. Next. So conventional workflow, always I told you this kind of experience you will have, and 5 to 8 appointments patient should come. Next. Digital workflow, the same thing I've told you, but my perspective is the primary and the final impression, whether it is an intraoral scanner it takes or the anything, but primary impression and the final impression as a prosthodontist or the clinical practitioners, you are the one to register it. Then up to the jaw relation record you have to register. Then you can give it to the lab for the occlusal perfections and the hybrid denture kind of easy manufacturing of 3D denture patterns. It is all available through the digital workflow and you can get it. Whatever the staining, the gum staining, everything is perfect through the digital workflow. Next. So the digital denture workflow. So I told you these impressions you have to take. Next. So why this interocclusal record is very important? Because when you are not registering the proper vertical dimension at occlusion and rest, that interocclusal record is a waste. So always you have to follow the oldest method only, the best method, the Niswagas method. You have to follow and register the correct vertical dimension. Then establish your centric jaw relation. There are many other methods to get the accuracy, like a Gothika's tracing method is also there. But normally how we are going to guide the patients to get a centric jaw relation, that method is enough and you can register. What is a centric jaw relation? It is a posterior relation of your mandible to the maxilla. It should not affect the condyle. Why? Because condyle should show the anterior most superior position against the slope of the articular eminence. So this kind of relation should be there. So there you can use a virtual articulators also. But virtual articulators, technology perspective wise, you can use a virtual articulators and virtual face bows. It is all there. But there are some, still now the research work is going on in that. Whether it captures the correct occlusal cant in the digital wise, so that is also there. So do manually and you can send it to the lab for the future processes. So 3D printed dentures. So as you all know, one is for dentures, the other one is for 3D printed dentures, the other one is milled dentures. What is the difference means? This is an additive kind of processes and that is a subtractive kind of processes. So in this additive, the thing is whatever the polymer, it is going to build it layer by layer. In the milled dentures, it is going to do the subtraction kind of. So it's going to do all the work in the ingot and you are going to get the milled dentures. So what is the difference? Because wastage of the material is more in the milled dentures compared to 3D printed dentures. And accuracy wise, 3D printed dentures are more accurate compared to the milled dentures. But moreover, the 3D printed dentures, one disadvantage is again you have to put it in the normal curing, then you can take it. But in the case of milled dentures also there is a problem. And curing wise, you have to some kind of long curing cycles you have to, the final restoration should be given. Next. So again, digital or anything. So initial cost, everybody, the technicians say, no madam, you have to pay 10,000, 15,000 like that. So that learning curve is there. Always will have the lacuna of knowledge. So the learning curve slowly should be improvised. And limited customization, because whenever you are going to do work with that, so all the records should be properly given to the patients and we have to depend on technology. Once you are entering into this market, always we have to depend on technicians and he will show all hi-fi kind of remarks. Madam, this is not good, that is not correct. So the learning technology is very important for all. Next comes accessibility. So very nearby, next to your clinic, the thing is there, the digital workflow is there. Easily you can adopt. So that is the thing I want to tell. Next. The fixed prosthodontics. Again, I told you, so one is over RPD and CD and fixed what you're going to make. So whether it is an one tooth replacement via the crowns or the bridges or through the implant or the root supported, whatever it is, you're going to make it in the fixed prosthodontics. Next. So the fixed partial denture. So what is your diagnostic perspective? So how well the bone is lost? So whether there is a classification, they'll say Seabird's classification. So whether there is a vertical height is lost or the horizontal bone loss, vertical bone loss, or completely it is including vertical and horizontal bone loss is there. So how well you're going to augment the bone and you're going to restructure it and again you're going to go for the replacement. functional perspectives. So again, this FPD, I told you what all the occlusal scheme it is possible, you have to rule out. So canine guidance, most of the patients, because of the wearing of tooth substance, the canine guidance will not be there. So re-restore the canine guidance, and then comes to your group function occlusion. So very, very important when you're going to do any kind of FPD work, always check for the canine to canine contacts, because this is the one will give a very good functional range of movements. So always it is not giving a pathologic. Suppose the canine is chipped off, so it gives a pathologic kind of movements, and the patient wear and tear will be, occlusal tear will be more. So technology perspectives. So how to rule out with the technology perspective, the design again. So one tooth is you are going to replace, so you can apply for the design, how well you can accept your shade guidance and other things through your digital scanning. So the occlusal scheme also you can very well record. So what is the purpose of T-scan here? It records the timing of occlusal contacts. Always you'll say, so what is the difference between the clenching and bruxing? So they'll say, because of heavier muscular forces, the patient will clench. So that is different from bruxing. So the timing of contact is very, very much needed. So you can utilize the T-scans for that purpose. So this is one of the very major kind of advantage in the utilizing the T-scan. Apart from the digital workflow, you can utilize the T-scans also. Next. Then shade selection. So always you have to have that shade tab, and you have to go whether it should be shown in the normal light or the blue incandescent light, whatever the light, so the shade will not be perfect. So how to reach out? So you can go for the colorimetry or the digital kind of shade guide. It gives accuracy. So this can be applicable for the maxillofacial prosthodontics also, right? So what is the advancement? Because in the digital workflow, easily you can check the margins, whether it should be corrected off. So that can be corrected in the patient mouth. So the gingival interaction technique. So now there is a newer kind of retractive method of expursal kind of materials are available. So that gives a wonderful gingival retraction. And then comes your digital innovations. You can check whether the gingival finish line and your whatever the finish line you are given for the patient according to the restoration, whether it has made it correctly or not. Then about the contacts and contours of the adjacent tooth also should be evaluated. Whenever you are going to give for any kind of FPD work, check for the contact and contours of the adjacent tooth. So if you are giving that kind of without checking the restorations, there will be open margins and patient may suffer with that. Okay, next. Then defective and atraumatic, I have told you this. Self-love opening. Next. 3M intraoral. Scanning experience, already you people know about the scanning experience, yes or no? The intraoral scanner, how we have to take it. So there is a digital show. Next. There comes implant dentistry. So why implant dentistry is nowadays, it's making a very good, future kind of prospective dentistry, yes. Patients always, they want, it should be fixed, it should be fixed. It should be fixed wherever it is, whether it is a tissue or the bone, it should be rightly fixed and it cannot be removed by the patients. It should be there forever. So now the augmented kind of reality and other kind of data, slowly it is growing up, and now they are saying the implants also can be fused to the bone. So that kind of superstructures if you add, it will not going to get failed, and whatever the loading you are going to give to the implant, there will not be any shown of sign of failures. So that kind of advantage is there. So this is the future perspective for implant dentistry. The treatment always data collection, whether it is a manual data or the technical data, you have to diagnose and you have to plan for your treatment. So again, I have told you, whatever the bone quality and quantity is a must. So whenever you are going to take any patients, why the quality affects. So as a oral medicine point of view, smokers, they'll say no. So it will end up in endoarteritis obliterans. So there will be a failure. So whenever you open a site for implant, there should be a good bleeding. Otherwise, if you don't have bleeding, it's a failure. So whenever you open the site for implant, if it is not showing a sign of bleeding, it's a failure. So always you have to check whether it is properly, that is the site is good or for the quality And quantity wise, you have to check the density of the bone, whether the cortical and the cancellous, whether according to MISH classification, they'll say class 1, class 2, class 3, class 4. So according to that, you quantify the bone, how much it is there, and densifying the units also, whether it needs any augmentation, that you have to check. Then surgery, whether the surgery people are going to place the implant or you yourself you are going to place the implants. The other modalities through digital, you can use your stents, the digital stent. Through that, you can place the implant. Next. So principles of design, whether it is so now the splinting concept is not there. Wherever you are going to place implant, one tooth missing means one tooth implant you have to place. So that kind of calculation you have to have. So now there are, the spacing and arrangement of implants. As you all know, everything, the bone width is very, very important before you are going to place any implant. The buccal and the lingual and the mesial and the distal, always you calculate next to the adjacent tooth. So always you have to leave 3 millimeters. Then around, the length of the implant is mandatory. Always go for 12 and maximum 10 to 12 millimeter of height implants is very much needed. And whenever you're going for the width of the implant, maximum they'll say 3.25 to 4, not maximum, more than 5 and all, it's a failure. So that you have to keep in consideration. And alignment and location of implants, the zigzag location also it is good, but only the prosthesis matters. So how you're going, very well you're going to deliver the prosthesis. And 3D positioning, that will give you the very good, how you are going to align the implant naturally into by 3D physiography, you can position the implant, and the same kind of stent, you can place it in patient and you can deliver the implants. And aesthetic considerations, anteriors, you have to check whether the bone loss is there, how well you are going to take it towards palatally, so that and all calculation you have to do. Whether you are going to give a cemented or the screw retained kind of implant. So where and all you can go for cemented, and where and all you can give a screw retained. But most of the cases the screw, it should be whatever it's a titanium screw. Sometimes what will happen, it will very cold welded inside the implant inner structures. So that is one of the failures. So always you have to give a passive fit of screws. Then implant components, always you have to, before you're going to place any implants, you have to configure which kind of implant system is very good. So you have to check what kind of implants are adjacent to the patient has placed. So there is an implant library is there. So this is one of the advantage of the digital workflow. Then you can check, and according to that you can place an implant. Then prosthetic materials, always go for a hi-fi kind of prosthetic materials, because it should have the very good, the masticatory efficiency. Whenever you are giving a patient any implant, don't overload immediately. So you have to maintain the waiting period. Maximum you have to, they'll say 3 months, they'll say. But there are concepts, immediate loading also you can do. But I cannot justify just like that, because I have seen lot of failures, because they are reporting to my college. So that time I can see immediate loaded implants also fail. So minimum the waiting period should be given. Otherwise you have to go for the augmenting the osseointegration. It should be perfect, means you have to go for the other kind of materials to coat the implant. That is the the bioceramic and active implants you can give. So those days they'll give hydroxyapatite. Now they are going for tricalcium phosphate kind of implant, coated implants. So that and all beneficial, because it maintains a near contact osteogenesis, and this will deliberately, it will improve your osseointegration. That is wonderful thing. And future prosto, I have told you, the implants will be very good, it is like a root, it is going to fix to the bone. So that kind of concept is slowly approaching. So there are many green synthetic materials also used to augment this kind of procedures. And finally, occlusion, don't overload the occlusion. Initial contact should be, so always don't go for the tripod contact, and the minimal contact you have to maintain for the implant for the 3 months. Suppose if you are loading it with the immediate implants, you have to maintain the 3 months, you cannot give just like that cusp to cusp occlusion. So you have to, or cusp to fossa occlusion. So everything like a minimum contact, and you have to give a freedom and centric concept also when you're designing for the implants. Next. So functional perspectives always. So why this functional perspectives is very important, because it combines both manual and digital. So then only it comes a very good outlook. So always gives a longevity and durability of your implants. So go for the very good implant system. And then the biomimetic kind of materials to increase the scaffold, so you can use it also. Then bone and tissue health always consider. So the quality is very, very important. When you're considering the patient is a smoker, better you tell him the implant failures are more in that. Then diabetic patients, the marginal kind of ranges and they are in control, they can go for, and long time of waiting period you have to give for them. Then comes patient comfort and satisfaction. So don't end up in failure. So always, if you want to make it success, follow all the prosthetic rules. Then technology perspective. So implant, whether it is a submerged or the collar level kind of implants, it can be scanned off, and according to that you can give wonderful digital workflow is there, and according to that you can customize kind of abutment also you can make it. Next.